Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of cutaneous T-cell lymphoma that was consistent with mycosis fungoides. So this is a case of a 72-year-old female patient who presented with generalized skin rash of a 3 years duration. One of those lesions was recently biopsied, and as you can see here, there is a busy upper dermis because of involvement or infiltration by the lymphoma cells. And as you can see here, there are a couple, and here as well, but this is much more clear, what we call Potrier's microabscesses. And Potrier's microabscesses are collection of the malignant atypical lymphocytes that are usually seen sitting within the epidermis, in particular the upper part of the epidermis. Now, zooming into the morphology of the cells, we can see some degree of atypia, not the usual atypical cerebriform pattern of a nuclei that you would expect with the typical mycosis fungoides, but still the overall appearance, the collection of the cells would really bring this important differential diagnosis into the mind of the reporting pathologist. Now, there is some degree of spongiosis, which is kind of unusual in mycosis fungoides, but sometimes can be seen, especially if the patient attempted some local medication. And now zooming into the upper dermis, the infiltrate in the upper dermis, where we can see that the infiltrate is kind of monotonous. There is same cells are repeated over and over. And to be honest with you, perhaps the first thing that would come to mind something else other than mycosis fungoides, because we don't see the usual cerebriform nuclei that we usually encounter with mycosis fungoides. Rather, one of the things that we should think of, perhaps this is kind of cutaneous T-cell lymphoma. And this is another field where we see the same kind of cells, and then these are surrounding the blood vessels. And a third field, again, replica of the previous two fields, showing exactly the same morphology, where we have really this monotonous, and it's extremely important to remember this word, that the infiltrate usually in lymphomas is monotonous. This is unlike the infiltrate that we see with dermatosis in general. There is a monotonous inflammatory cell infiltrate that we can identify here from similar cells in one field to the other, with the larger nucleus and sometimes the prominent nucleolus. Now, on higher power magnification, and this is the oil immersion, just to give you a feeling of the appearance of the nuclei of the tumor cells, some histiocytoid appearing cells here, others perhaps with some cleavage of the nuclei with the prominent nucleolus, kind of cerebriform appearance, and again here another form of the nucleus, a nuclear appearance with the nucleolus, and some abundance of the cytoplasm. But in general, if you see, the cells are more or less similar to each other. Now, looking into the immunohistochemistry, first of all, we want to know what is the nature of the tumor cells, and the CD20 is almost completely negative, while the infiltrate is positive with CD3, and the infiltrate also shows positivity with CD5 and more or less to CD7. So there is no loss of antigenicity with CD5 or CD7, as you would kind of expect, especially with mycosis fungoides. CD2 is also positive, beautifully showing the positivity with this very perhaps unusual pattern of staining with the dot-like cytoplasmic staining, but in general, this is positive. Now, what is really important, that the tumor cells were almost exclusively positive with CD4, with merely any CD8 positive cells in the background, as you would expect in most dermatosis. This is extremely important. So the tumor cells are positive for CD3, CD5, CD7, CD2, and they are positive for CD30. Now, because of the appearance of the tumor cells with the slightly larger nucleus and the prominent nucleolus, and the possibility of perhaps anaplastic transformation or anaplastic large cell lymphoma, CD30 was performed, and in general, CD30 is completely negative. So the final diagnosis in this case, based on the long clinical history, the involvement of the generalized skin rash involving the body, and the immunoprofile is consistent with T-cell lymphoma of mycosis fungoides type, perhaps most consistent with the tumorous stage. Remember that in mycosis fungoides, you would see the tumor cells positive in general for CD3. There is usually, but not always, loss in particular of CD7, although this is not a mandate to establish the diagnosis. CD5 and CD2 are in general preserved or maintained. And remember that the tumor cells show this beautiful positivity that I shared with you for CD4 in the presence of CD8 negative staining pattern. Remember that when you have this atypical appearance, that you have either to consider anaplastic transformation of mycosis fungoides or anaplastic large cell lymphoma, for which CD30 is extremely important to support the diagnosis. I hope you find this tip useful in your daily practice. Thank you.